Okay, now we're going to do some additional muscles, starting with the muscles of the foot. Now these muscles, these don't have to be done all the time, but when you have a suspicion of a polyneuropathy, then these are definitely indicated to do. If you have a suspicion of tarsal tunnel syndrome, then the two tibial muscles are definitely indicated to do. Or if you're having a low amplitude response of your traditional motor studies, again, in line with a polyneuropathy, or even as far as the EDB for a radiculopathy, these are muscles that should be checked. So we're going to do the extensor digitorum brevis muscle, we're going to do the abductor hallucis muscle, and we're going to do the ADQ, the abductor digiti quinti. So we're going to do those three muscles. So again, these muscles they're a little challenging in the sense that these are a little uncomfortable. And the EDB especially, the EDB is a smaller muscle, and it is not very deep. It is quite superficial. So when you're inserting the needle into the EDB muscle, you're not going to insert it directly in this way. You can see his EDB nice and big right here. Just bring your toes back a little bit. Bend your toes back. You can see the muscle there. You're not going to insert because you'll go through it. What you'll do is you're going to kind of pierce it like this way. Kind of like taking a shish kebab and kind of having the needle go through the muscle this way instead of going deep in through it. So that's how you can get that muscle there. So we're going to prep the area. You can take an alcohol wipe. And make sure you let this dry because this can be a little uncomfortable. So we're going to come over here to the EDB muscle. We're going to go to the adductor hallucis on the inside, and then to the ADQ down over here. So those are the three muscles we're going to demonstrate in this procedure. So for the EDB, again, the patient is going to be in this comfortable position, and the motion is going to be extension of the toe. So that's going to be the motion we're going to come in through there. And when we insert the needle, we're going to insert it going this way. So we're going to insert the needle in going through that way. I have my ground and my reference on the area. My sound is on. Okay, so I take the needle. Okay, I can make the skin nice and taut to make it a little bit more tolerable. And again, piercing the needle going through that way. Okay, so nice and relaxed. Here we go. Feel okay? Yeah. Okay. I turn the machine on. And there's some, so he's getting a little bit of contraction. Actually, those are end plate spikes again. So you're seeing those sharp negative movements. So I just moved the needle and it went away. So again, end plate spikes are not a normal phenomenon. The needle tip is too close to the neuromuscular junction. So there's my first depth. Go a little deeper. There's second depth. There's third depth. Extract the needle out and redirect. There's end plate spikes again. So I move the needle. Depth number 2, depth number 3. So again, I'm waiting a second too to make sure there's no spontaneous potentials. Extract out, redirect. 1, 2, 3, good. One more quadrant. Extract out, redirect. And a little bit of increased social activity. Good. Good. So nothing normal there. One area had increased social activity, but not sustained. So I'm going to stop that buffer and store that under EDB. Good, that buffer stored. Go back to live again. Go to 200. Now again, this one, the motor units are going to be very large. So very, very gently, try to bring your toes up. Good, and we're giving you a nice good recruitment right away. So this one is very easy. When the muscle is present, it's very easy to get good contraction of that muscle. So there's a motor unit there. I'm going to put the needle in a little different location. There's a second motor unit. Good, hold that contraction. Good. Good, there's different motor units there. I'm going to redirect it slightly. Good. Good, there's another nice motor unit there. Again, he's barely moving, but we're getting nice, good motor units there. Find one more. Nice and crisp one. Bring your toes back. There we go. Bring your toes back. Good. Some nice motor units there. all normal shape, normal amplitude, normal duration. Let's pretend that was 12. So I'm going to stop that, store that buffer, go back to live. And again, this one should get decent recruitment. So very gently, bring your toes back. Good. Looking at the amplitude, looking at, seeing, now go a little bit more, a little stronger. Got good recruitment there. Go a little bit more. A little more. A little more. And relax. Good. So I'm looking for the motor units getting more of them, looking at their firing pattern and looking at to see if they fill the screen, and they all did, and that was good. So that was the EDB muscle. So again, this one is a good perineal muscle, especially if you have low amplitudes of the perineal motor, to check this muscle. Or if you suspect, again, polyneuropathy, this is one of the distal muscles. It's not the most distal muscle, but it is a distal muscle. With this muscle, you should kind of be somebody with that over 60 or 70. That muscle would normally atrophy, so it will be a little bit hard to get that muscle. So that might not be the best muscle to check if it's so atrophied, because you won't be able to feel it and see it as well. So that's the EDB muscle. So next one, we're going to do the abductor hallucis. Now the abductor hallucis is a bigger muscle. I'm going to go to my screen and select it. Turn my amplifier off first. Go to abductor hallucis. Now the abductor hallucis is a bigger muscle, so it's going to be easier to insert the needle and to palpate. The difficulty is getting good activation of the abductor hallucis, because it's very difficult for the person to abduct their toes. It's not a motion that's normally done. So the way you can get around that is if you ask the person to bend their toes down and out. So if the person bends their toe down and out, the abductor hallucis kind of gets activated secondarily. So they're kind of activating that muscle that way. So let's see you push your toe down and out, push it down to my finger, and there, he's got good motor activation, a little bit of abduction, so that's good, that's what we want to see, and relax. So that's where we're going to insert the needle. Again, the palpation of the abductor hallucis is there's the navicular bone, and about one finger towards the sole is the location of the abductor hallucis muscle. So that's where we're going to insert here. Okay, there we go. So I have my gain set at 100. I'm going to come in, and I'm going again in towards an angle. So I want to get the muscle runs from here, from the calcaneus, all the way up to the metatarsal head. So I'm going to insert it at that angle. Okay, so nice and relaxed. Here we go. Feel okay? Yeah. All right. Okay, now bend your toe down. Make sure you're in the muscle. So we're not there yet. Okay, now we're in. You hear those nice motor units there? So now we're in the muscle. So now we can relax. Now we can do our same coning technique. So 1, relax. 2, 3, extract it out, redirect. 1, 2, a little bit of increase in stress activity. Yep, see all those blips afterwards? That's a little bit of increase in stress activity. But again, with these foot muscles, they take a beating. So they're normally going to be a little bit more hyperactive than normal. So I have to see some more spontaneous potentials for me to call that abnormal, significantly abnormal. So there's some, again, more increase in social activity. Good. I'm not moving, but I'm getting a little bit of blip discharge afterwards. Good. Okay. So let's store that, stop it, and store that buffer. So we stored that buffer, and again, if you want to, let's just mark it as increase in social activity, but whether or not that's clinically significant is, that would be a bigger picture, but usually that's not, just insertional activity alone in that muscle is not clinically significant. So now I'll go back to live again, and I'll go back to live. I'll change my gain to 200, and now again, I ask the patient to do a very gentle, push your foot down, push your big toe down, and I'm getting some nice motor units there. So I'm getting some nice motor units. Again, normal shape, normal amplitude, normal duration. Good, he's getting 1 or 2 on the screen at a time, which is perfect. Very good, a little bit too strong, just a little bit less. This one I tend to have the person relax as I direct it, because this one hurts a little bit. Okay, push down. Good. Going a little bit too hard, just a little less. Goes push down a little bit. Good. See, that one there is big, so that one has a little bit increased duration. So that motor unit there, let's stop it. Good. I'm going to rewind that a little bit. You doing okay? So I'm going to rewind it, and we can see that those two motor units both have increased duration. We have, see where it starts over here, and this where it ends over here. So that's increased duration, and this one is also increased duration. So these two motor units are a little bit long duration as well. You have any problems in your legs or your back?
No.
Okay. Well, it's just a little bit. Again, it may not be a lot significant, but those two motor units there are have increased duration. But again, we want to find more. So let's just store that buffer file so we have it. And I'm going to go back to live again, and we'll see if we see some more of those. Okay, push down. Good. Those back to normal again, so good. So again, just one abnormal motor unit does not make the whole muscle abnormal. So we saw two of them that had increased duration. Those ones, the duration is normal. So we're back down to normal again. So again, that's why you need to assess at least 12 motor units in each muscle to make sure that the muscle is not abnormal. One abnormal motor unit in the muscle does not make the muscle abnormal. So those are back to normal again. So we can relax. I'm going to store that second buffer file. So I hit stop, and now I store it. Good. Now I'll go back to live again. And to get full interference, this one is going to be pretty easy. Very gently start down, push a little bit. Good, there's some motor units there. Go a little bit stronger. Good, go a little more. And a little more. And a little more. And a little more. And relax, good. So we got nice, good interference pattern with that one. Stop the screen and store the live buffer. Okay, take the needle out. Sometimes with people with diabetes or other problems, the foot muscles will tend to bleed a little bit. In this case, we didn't have it, so that's good. So that is the abductor hallucis. Okay, and then finally we'll go to our last muscle, the AD on the foot. We'll go to the ADQ. Okay, so the ADQ, we're going to have you turn your foot this way a little bit. We'll go over here. And now the ADQ is going to be between the calcaneus and the head of the metatarsal. So there's the metatarsal, and there's the calcaneus. So the ADQ is going to be right in between there. And again, and this is a tricky one in terms of activating the muscle. It's going to be difficult to get abduction of the big toe. So again, kind of flexion and down and out, flexion and abduction by default will kind of get you a good kind of palpation of that muscle. So that's going to be that motor unit for that muscle there. Okay, so I take the needle, put the skin on nice and taut. Okay, there we go, nice relaxed, here we go. Feel okay? Okay. Okay, we're not in there yet, so let's redirect it, angle it differently. Okay, let's angle it differently. Hang in there. Okay, let's go this way. There we go, now we're in. So just angling a little bit differently. Now we're in the muscle. Okay, if you want to check it, bring your toes down. And now perfect, now we're in that muscle there. So sometimes you just got to change the angle of orientation. You feel okay, hanging in there? Yeah. All right. Okay, so there's that first muscle. There's the first depth. One and second depth. Relax, relax. It was nice regular, so I know it wasn't insertional activity because it had a nice regular steady beat to it. There's one quadrant. Extract out, very gently redirect it. Relax, good. That was a motor unit. Good. Good. Oh, okay. Okay, needle came out, so put a little piece of pressure here. So sometimes these superficial muscles, when you're going close to the surface, sometimes the needle will slip out. So when it does, just take a little pressure. The needle didn't touch anything, so the needle can still be used. So the needle is okay. So put a little pressure there. Now you're not going to go in exactly the same place, but you're going to go near to it. Stop the buff, stop it for, I'm not going to stop it, we'll go back in. And come right next to it, here we go. Good. Okay, push down. Okay, relax. Angle it just a little bit. There we go, now we're back in. Okay. I'll pick up a little noise, so I'll put this on here. So let's store that buffer file. Stop it and now store it. So there we go. Okay, go back to live. Now we'll go to 200 again. So now very gently push your toes down. Good, getting some nice motor units there. Good. I'll just put it just a tiny bit deeper. So there's some more motor units. Again, all normal. Push a little deeper. All normal, very good. Okay, so let's pretend that was 12. So let's stop that buffer and relax, stop it. You can relax, freeze it, and store the live buffer. So that's stored. Now we'll go back to live again, go up to 500 on the gain. Very gently, push your foot down, push your toes down. Good. And a little stronger. Good, a little more. A little more, a little more, push, push, push. And we get some nice interference pattern with that one. And relax, good. Stop it and store the live buffer, good. Okay, take the needle out. Let's put a little pressure there with a little bit of blood, nothing too bad. So those were the foot muscles. So that's what you have to be kind of just watch out for a little bit is when you're going in so superficial to the muscle, sometimes the needle will come out. If it does, just make sure it doesn't touch anything. If it touches something, just you gotta discard that needle because then it's picked up whatever is on the surface. So you don't want to put that into the patient. But in this case, the needle didn't touch; it was still in my hand. So I just redirected. I just put it into a different location. I didn't put it exactly back where it was because that will be a little bit uncomfortable. So I just moved it just slightly next to it. So that was the foot muscles. So now we're going to come up. And we're going to go up to the upper extremities, and we're going to do some muscles of the upper extremity. So we're going to switch this here. Okay, so now we're going to do some upper extremity muscles again. So now I switched my needle to a green, because these are a little smaller, so we can use the green needle. So we're going to do the extensor digitorum communis. So it's going to be similar to the extensor carpi radialis longus, but just more in the center base of the palm. This one would be good for posterior interosseous muscle because the posterior interosseous nerve, not muscle, posterior interosseous nerve, the EDC would be abnormal while the extensor carpi radialis will be normal because extensor carpi radialis is innervated before it branches off into the posterior interosseous. So we're going to do two muscles from the radial, the extensor digitorum communis, and then the extensor indices, which is another good posterior interosseous nerve muscle and another C8 muscle. Then we're going to do the abductor digiti minimi, which is for ulnar innervated for cubital tunnel syndrome. And then we're going to do flexor pollicis longus for anterior interosseous nerve injury. So I have my needle here, place it in the needle holder. Plug the needle into channel number 1's active. Take a little alcohol wipe. We're going to do EDC, extensor indices, ADM, and then I'll clean FPL before we go to that. So I'll clean that there since we're going to put that down anyway. All right, so let's go and we'll select EDC first, put that there. Then we'll do extensor indices, ADM, and then FPL. Okay, so extensor digitorum communis. All right, so I have 100 now. So again, this is going to be, the motion is going to be extension of the wrist. So bring your wrist up, push up. And there's the extension of the wrist. There's a muscle there. Okay, and I'm going to, again, insert it going proximally, going up that way. Okay, good, relax. Okay, let the alcohol dry. There we go, good. take the needle out. Again, inserting the needle in this way. Okay, nice and relaxed. Here we go. Okay. Okay, I'm in muscle. Let's make sure I'm in the right muscle. Bring your wrist up, and I'm in the right muscle. So there we go. So I know I'm in muscle. Relax. So I know I'm in muscle. Then I ask the person to do the motion, and the motion is what I want. Then I'm in the right muscle. So now I'm in the right muscle. So the same procedure as always. And these are coming off a little bit, so I'll replace these in a second. So first depth, 1, 2, 3. That's my first quadrant. Extract out, redirect. 1, 2, 3. Second quadrant. Extract out, redirect. 1, 2, 3. Third quadrant. Very small angle that I'm changing. 1, 2, 3. Good. There's my 4 quadrants. Okay, so I'm going to stop it. Store that live buffer. It's on EDC. Store it. Good. Go back to live again. Go up to 200. Okay, very gently bring your wrist up. Good. Okay, a little bit less. Good. So I'm getting some nice, very thin motor units there. Normal amplitude, normal shape, normal duration. Good. I move the needle a little deeper. Get some different motor units there as well. Normal shape, normal amplitude, normal duration. A little less. Good, perfect. Okay, I'll change the angle. Okay, relax, relax. Change the angle a little bit. Come this way. Okay, bend up. There we go. There's some nice motor units there. I'm applying my resistance at the knuckles. So I get motion of the wrist. Good, there we go. There's a nice normal motor unit. Go a little deeper. There's some more motor units. Nice, sharp and crisp. Normal amplitude, normal duration, normal shape. Very good. And relax. Okay, I'm going to stop it. Store the live buffer. Buffer stored. Go back to live again. Increase to 500. Very gently. Try to bring your hand up off the table. Good. Now go a little stronger. Good. Looking for those increase in size. Go a little more. And a little more. Okay, I'm not really getting good, so let's move into a different location and see if we can get good baseline, a good interference. Okay, here we go. Okay, now bring your wrist up. Good. A little stronger. A little more. There we go. A little more. A little more. A little more. A little more. And there's a good obliteration of baseline, and relax. So we got nice good obliteration from baseline, so we can stop it and store that buffer. Good. So that's the extension of the digitorum communis. Let's turn the preamp off. Take the needle out. If we see a little blood there, put a little pressure on it. Okay, so next one, while I'm putting pressure, I can get palpated for my extensor indices. So the extensor indices is about 2 or 3 finger breadths proximal to the ulnar styloid process. And this motion is just going to be extending of the index finger. So you'll ask the patient to lift their index finger up and down off the table, and you can kind of feel where that muscle is. So I can feel that muscle underneath my 2 fingers here. So that's where I'm going to place the needle. And when I insert it, just as the other ones, I'm going to insert it at an angle going proximally, because that's how the muscle runs. It's a very small, thin muscle. So I'm going to insert it, angling it upwards towards there. And this one, again, because it's so small and thin, you may have to slightly change your angle a little bit to get good location of the muscle. So I'm going to get my screen set up for extensor indices. There we go, back down to 100 on my gain. Okay, my machine is off. Take the needle here, out of the sheath. Okay, nice and relaxed, here we go. Okay, needle's in. Turn it on, let's check if I'm in the muscle. Bring your finger up. Okay, not yet. Go a little deeper, see if we can get to it. Okay, I'm in something. Let's bring your finger up. Not quite. Okay, bring your finger up. There we go. Nice and crisp, somewhat. All right, let's move it a little bit angled. See if we can get that into that muscle. Nice motor units there. Okay, bring that finger up. There we go. Perfect. Now you got some nice crisp motor units there. So again, this one, you can't go that very far. Relax. There's not that many motor units. There's not that long of a muscle to go to. So we're in the muscle now. So let's do our depth quadrant technique. 1, 2. Relax, relax. Good. Extract out. Redirect. 1, 2. Ran out of needle. Extract out. Redirect. 1, 2. Only getting 2 times, but it's the same procedure. You may need to go to different locations, but you're getting a good assessment of the muscle at rest. Relax. Good. Good. So that's assessment of the muscle at rest. Make sure you don't have your finger wound up. So stop that. Let's stop the buffer. Store it on extensor indices. Very good. Okay, now we'll go back to live again. And we'll go to 200. So we want to get some motor units. So bring your finger up a little bit. Perfect. Good. I'm getting some nice motor units there. Those are normal amplitude, normal duration, normal shape. Very good. I can extract it a little bit. Push up again. Again, different motor units because they're different shapes. Again, all normal amplitude, normal duration, normal shape. Good, and relax it. I'll extract it out a little bit one more time. Push up again a little bit. And now they're getting too dull, so I'm not near it again, so I need to redirect it. So let's redirect it very slightly. Okay, push up a little bit. Oh, that's very dull, so it's not near it. So I need to extract it and go back to where I was, go back to the same direction. Okay, let's find the placement again. There we go. Now nice and sharp. Good, hold it like that. There's some nice motor units there. Normal amplitude, normal shape, normal duration. Very good. So let's pretend that was 20. So relax it there. Stop it. I'm at the 12. Stop it. Store the live buffer. Good. Now I'll go back to live again to get interference and recruitment. So very gently bring your finger up. Good. Now go a little stronger. Good. They're getting more motor units. Go a little more. He's getting some more. A little bit stronger. A little more. A little more. And relax. Good. So that was the extensor indices. Got good. Relax. Good. Got good interference. Stop it. Store live buffer. And go back to live again. Okay. Now we can take the needle out. Doing okay? Okay, put a little bit of pressure there. Now the adductor digiti minimi is the next one we'll do, or the ADM muscle or ADQ of the hand. So the ADM, again, this one is useful for, again, polyneuropathies as well, also for ulnar nerve injuries, either at the wrist or at the elbow, more common at the elbow. So this one is just going to be moving the small finger or the pinky finger out to the side. So it's the only muscle here. So you can ask the person to move your pinky finger out to the side, push out, and relax. So there's the bulk of the muscle there. Don't have to go in too deep. So we're going to go right in here. We can move these down a little bit so we get ourselves a little bit closer. All right, so we're at on ADM. That's good. Okay, so I'm going to come in and I'm going to insert it just in right through here. So this one is not going to go in very deep. We're going to insert it right through here. Okay, nice, relaxed. Here we go. Feel okay? Okay. Now we're in. That's the only muscle there, so I don't have to check it, because if I hear it, that's the only thing that's there. There's 1 depth, 2 depths, 3 depths. Good. Extract out. Redirect. 1, 2, 3. Good. Extract out. Redirect. 1, 2, 3. Good. All quiet. 1, 2, 3. Good. All resting. No noise. Store that. Stop it. Now store the live buffer under ADM. That's good. Now we'll go back to live again. Go to 200. Okay, now very gently push your finger out to the side. So we're getting too many already. So there we go. Now there's a polyphasic one there again, but the hand takes a beating just like the foot does. So it's expected to see some polyphasics, but that's 1. But we need to see more. We need to see more than 30% in order for us to label that muscle as abnormal. So let's see if we can find other ones. So just keep that contraction. There, move the needle again. So now that one has, hold that contraction, push out a little bit. Good. Nope, it went away. So that was normal. So that motor unit, that polyphasic didn't sustain. We get one there with a couple of turns, that larger one, but it doesn't cross the baseline. So again, that's normal. So I move it a little deeper. Again, I'm seeing nice normal motor units again. Doing okay? Okay, the patient's doing okay. So I can extract it, try a different angle. Okay, push out a little bit. Good. Too much, too much. This one is very easy to blow the motor units away because this muscle is so small. Smaller muscles tend to have better activation of the motor units because they're more for precise control. There's a nice normal motor unit. Good, a perfect one there. Let's try to keep going. There's all normal ones again. So again, we saw one abnormal polyphasic in the beginning, but overall the rest of them were all normal. So that's not significant. So I can stop that buffer and I can store that live buffer. Good. Now we'll go back to live again. I'll go up to 500. And now very gently try to push your finger out to the side. And a little bit more. I'm seeing if there's more motor units being activated, which there are. And go a little bit more. And a little more. Again, this one is quite easy to get good activation, which he does, and relax. Good. I can stop it, store the live buffer, stop the buffer, and store it. So that is the ADM. Take the needle out, look for any bleeding, just little drops, so I'll put this little here. So that's the ADM. And then finally, we'll have them ask him to turn his arm over, so I'm going to take this off for a second. Just going to put a little pressure there. So that was the ADM. Now I'm going to go to the flexor pollicis longus. Okay, so now if I can ask the patient to turn their palm up, face this way. Now the flexor pollicis longus is a muscle innervated by the anterior interosseous nerve, and it's quite distal. So, and that's just going to flex the thumb. So flexion of the thumb is coming down this way. So let's have you bring your thumb down in that direction. Bring your whole thumb like that. Good. Push it down again and relax. Good. And push it down again and relax. Good. So we're coming in here. That's where we're going to insert the needle. So let's swab it down with alcohol first. There's our alcohol wipe. Coming in there. Good. And again, this one is a little bit of a trial and error one as well, trying to find the exact location. Usually I don't tell patients to trial and error, but sometimes you have to try to find it. Okay, let the alcohol dry. Okay, so again, FPL coming in right here. So bend your thumb down, bend it down this way. Good, I can feel a little bit muscle there, so relax. So that's where I'm going to insert the needle. Okay, nice and relaxed. Here we go. Okay. Okay, bend your thumb down. Okay, not there. So let's move it. There we go. So there's the muscle. I'm in the muscle because he's doing the motion and I feel the resistance. I hear the motor units. So I'm in the muscle. Good. Okay, relax it. Relax, relax. Good. Relax, relax, relax. There we go. Good. Now I got him thumb relaxed. So now I can try to assess for resting potentials. Relax, relax, relax. Good. So I push him into more flexion, so that helps him to relax a little bit. Good. Those are motor units. Try to bring your thumb back. Push it back. Give it thumbs up. Nope, still getting some motion. Relax, relax, relax. There we go. I forced him into extension. That helps to relax it. So now I can do my insertional activity. There's 1, 2, 3. Good. 1, 2, 3. Good. One more time. 1, 2, 3. Good. So I had to force into extension to get him to relax. That's what I had to do. So that's good. So now we can stop it and store the live buffer. Good. Stored. Okay, go back to live again. So now it should be easier for him to get contraction. So push down. And there's some good flexion of the thumb. Again, this muscle is not one that's done routine, but it's good for anterior interosseous nerve injury because FPL is one of the muscles innervated by the anterior interosseous nerve. So I got some nice motor units there. Okay, push a little more. There's another motor unit. That one, you got one polyphasic there, again, but nothing too significant. Okay, push, there's a normal one again. So again, one polyphasic and the rest of them are normal. Relax it. I'll redirect it just a little bit. Okay, push down. There we go. There's a nice normal motor unit. Two normal motor units there. Normal amplitude, normal duration, normal shape. Very good. So let's pretend that was 12. So I'm going to stop it. Store live buffer. Go back to live again. Go to 500. This one should be pretty easy to get good recruitment. So very gently push your thumb down. Good. And go a little stronger. Good. Go a little more. A little more. Good. A little more. A little more. A little more. Push, push, push. Push, push, push. Push, push, push. Very good. Very good. And relax. Good. Let's try one more area. See if we can get a little bit better, but that's pretty good. Nope, lost the muscle there. Okay, push down. There we go. Okay, a little stronger. A little more. And relax. Good. So there's the stop it. Store live buffer. Very good. Take the needle out. And again, the textbook would say that you need to just be aware of the radial artery. Again, as long as you're not anywhere too distal to it, you're still going to be within the muscle. So, you know, don't stick the needle. The muscle does go all the way down here next to the radial artery, but as long as you're staying as far away as I was, nice and proximal to it, you're going to be not at risk for piercing the radial artery. So those were the additional muscles of the upper and lower extremity for the distal muscles.